hospital. He was a 55 years old male, smoker and hypertensive, presented by shortness of breath, fever of 38.5 and desaturation of 80% oxygen saturation. Arterial blood pressure was 110/70, heart rate was 110 beats per minute, and his chest showed scattered crepitation all over the chest. Cardiac showed an S1, S2, and an S4. At the chest triage, we have a chest triage for seeing the patient who suspected COVID. He was administered oxygen, intravenous furosemide of 80 milligrams. The COVID PCR was negative, and he had a previous COVID PCR 1 day ago, which was also negative. The COVID IgM was positive. His ECG showed diffuse ST segment depression in all the chest leads with ST elevation in lead AVR, and his bedside echo showed an ejection fraction of 35%, global hypokinesia, mild mitral regurgitation, dilated left atrium, and normal right side. This is the chest X-ray at the ER, as you can see here, full of lung opacities, denoting the chest crepitation that were scattered all over the chest. And this is the CT scan of the chest, showing a picture of aggressive pneumonia, viral pneumonia, probably COVID in this pandemic, infiltrating both lungs. Few minutes later, while arranging for an ICU bed, the patient gradually desaturated down to 64%. He was intubated and mechanically ventilated. He was shocked, blood pressure, inotropes were started, and blood pressure was 90/60 on inotropes. The lab results arrived, showing elevated cardiac troponins 4,500, CBC showing a platelet count of 180, total leukocytic count of 18,000, and hemoglobin of 13 grams per deciliter. CRP was 30, creatinine was 1.3, and the liver function tests were normal. What would you do? Case summary: this is a 55 years old male, smoker, hypertensive, fever, desaturation, intubation, ventilation, then shock on inotropes. COVID PCR negative, but IgM denoting a recent infection was positive. ECG echo and trope suggestive of non-STEMI. And the past history from the family showed a right fem pop bypass, left common femoral artery stents, left subclavian artery surgical thrombectomy. I mean extensive atherosclerotic peripheral arterial disease. So, as you can see here, the stents on the femoral. And next day at 8 a.m., we performed a diagnostic angiography after stabilization on the mechanical ventilation on inotropes. As you can see here in the caudal view, there's a left main disease at the distal segment involving the ostial LAD and mid-segment circumflex lesion bifurcating with the OM, and another long segment in the mid-LAD that will be seen as we go through the videos. I think you can appreciate the collateral supplying the CTO of the right coronary artery as well, septal collaterals. So we have a heart team at the hospital. We called the cardiac surgeon. He was there and he met the family and he spoke with us after he saw the video. The cardiac surgeon and the family agreed that this patient would perform a CABG for his coronary anatomy, which would be a very good situation, but unfortunately the COVID infection is not an optimum situation for the patient to receive general anesthesia and perform an open heart surgery. We discussed with the patient that this is a very high risk procedure involving a left main intervention, and they signed the high risk consent, including the mortality, and the patient was ventilated and intubated at the time of the procedure through the right radial artery approach. So this was the diagnostic angio to revise the lesions in the circumflex, in the LAD, in the left main, and the septal collateral supplying the RCA. And we started by a guiding EBU and wiring of the LAD and the LCX, pre-dilatation of the LCX in direction of the OM with a non-compliant 3 millimeter balloon to break the calcium. It was difficult to pass the stent, and then we passed the stent from the LCX to the OM. This was a 3x34 onyx, post-dilated by a 3.5 non-compliant balloon, as you will see. And then this is the result of the LCX after dilatation with a non-compliant balloon. Satisfactory result in the CX direction the OM. Then we pre-dilated the LED by 3 mm non-compliant balloon first to break the calcium and the left main also. And this was a 3.5 by 34 onyx stent also inserted in the mid segment of the LED. As you can see, the calcium shadow. The stent was inflated at high pressure, followed by dilatation of the left main also. And this is after stent placement. And this is a 4.5 by 26 onyx to the left main and the proximal LED. You can see the tight lesion at the ostial LED was the last one to yield. This was inflated at high pressure also. And then this will be followed by flaring at the left main ostium, as you can see. This is a 3.5 non-compliant balloon used for proper apposition of the LED stent, inflated at 22 atmospheres. Because of the calcification, impaired the proper inflation of the long stent. This is a 4.5 millimeter balloon for the distal left main, and this is a 5 millimeter balloon for the pot at the left main, as you can see, adjusting the distal margin at the flow divider. And this was withdrawing the wires after performing the procedure. And this was the final injections for this patient. The post-intervention scenario, the inotropes were weaned in the first 12 hours. Mechanical ventilation continued 48 hours invasively and 72 hours non-invasively via CPAP. The patient was transferred to the chest ICU for the post-COVID sequelae of lung fibrosis. He had extensive lung fibrosis, and he was actually removed from the chest ICU in a regular room in the department, actually on oxygen concentrator in a regular room in the chest department. And then he was discharged to a regular room at his home with the oxygen concentrator. And this patient has actually been recruited for the lung transplantation program starting in the University Hospital next month, inshallah. Thank you so much. Thank you.